I'd like to welcome you to this session on COVID pneumonia and non-invasive respiratory support. So on that note, we've also announced a change today. Unfortunately, the presenter that was scheduled to speak today is not well, and you can't force someone who's not well to just speak like that. So we got Prof. Greg Caligaro to take over, and we'll be talking about non-invasive respiratory support.
I'm going to be talking today specifically about respiratory support outside of the realm of mechanical ventilation in COVID pneumonia. And I'm going to be talking about a couple of proprietary non-invasive systems. So just to mention that I've got no disclosures and I have no association with any of the companies that I'm going to talk about. So what I'm going to go through today is describing the respiratory symptoms and radiological characteristics of COVID pneumonia, what the rationale is behind non-invasive support, both in terms of logistics and pathophysiology. I'm going to discuss different forms of oxygen therapy and how we escalate those therapies up the oxygen ladder. And then we're going to talk about different forms of ventilatory support. The one form of respiratory support that's really emerged as a really valuable resource in the COVID era has been that of high-flow nasal cannula. And I'm going to talk specifically about that technology and how I think it can be used more extensively, particularly in the setting of reduced access to ICU beds. We're going to talk about proning as a measure to improve oxygenation. So both proning on ventilators as well as proning of awake patients, which is something that they can do themselves. I'm going to briefly discuss a case study, so like a typical patient that we see in our service. And then lastly, I'm going to just touch on some of the outcomes with high-flow nasal cannula at Kritiski and at Tygerberg. In the interest of time, what I'm not going to talk about today, and it's going to be covered in a completely separate lecture by Malcolm Miller, is the specifics of the mechanical ventilation of patients with COVID pneumonia and severe ARDS. Right, so I'd like to start off with this very first report from Wuhan, China, looking at the clinical characteristics of patients hospitalized with COVID pneumonia. And I think it's important to note that in this early study, all of the admitted patients had radiological features of viral pneumonia. So these weren't people that had asymptomatic infection or mainly upper airway disease. They all had pulmonary infiltrates. And as we have seen, and those of you who treat patients with COVID will know, that even in the presence of pulmonary infiltrates, the incidence of patients actually complaining of being short of breath is actually quite low. So in this study, only about a third complained of being short of breath. Their main symptom was dry cough. And interestingly, up to a third had cough with sputum. So this is certainly not a pathognomonic feature, a dry cough. And while symptoms developed after about 5 days, the onset of severe respiratory failure, so ARDS as we know it, developed at about day 8. And we're talking specifically about the group of patients who were hospitalized. ARDS developed in 20%, so about a fifth of the cohort. And of those patients, 12% required mechanical ventilation. So as you can see, there's a big group of patients who are hospitalized who aren't particularly unwell. Then there's your group of patients with ARDS who require some form of non-invasive support. And then there's the group that require ICU admission for ventilation. And I think it's interesting to compare this with a much larger cohort from New York. So this was, it was 5,700 patients. But the incidence of both respiratory failure and of mechanical ventilation was about the same. And I think the early reports, which have been quite concerning, showed this very high mortality in the group of patients that were ventilated. And in this new cohort, the rate of ventilation was about 88%. So what about radiological findings? So those of you already would recognize this X-ray quite easily. Early in the disease, you start with bilateral, usually multi-lobar ground glass opacities, which classically are peripheral and basal. So you can see that in this X-ray, the bases are relatively spared. And as the disease progresses, you get consolidation superimposed on these ground glass opacities. And you can see how in day 8, these opacities have kind of spread out to involve all but the very apices of both lungs. And it's interesting that older patients tend to develop more consolidation than ground glass opacities. So as the disease progresses, and you'll remember that I said the median time to respiratory failure was about day 8, while the median time to kind of worst radiological abnormality is 10 days. So that's when the severity on the X-ray at least peaks. And you've got the transformation of these alveolar infiltrates into more confluent areas of opacification. And as patients improve, the reverse process occurs, and you get defervescence of those infiltrates and opacities until the chest X-ray eventually clears. And we don't really have a good understanding of what the natural history is of lung function abnormalities and radiological changes. And certainly we've seen people with persistent oxygen requirements and radiological changes that extend into weeks after their COVID positive test. So Graham is going to go through this in more detail when he talks to you about the treatment approach, but I think lots of you will have read or heard about treatment protocols. At Crivascare and at UCT, we're using really the only evidence-based therapies for COVID, which is oxygen and dexamethasone. Remdesivir is the other agent, although that isn't available in the public sector at least, and not yet in the private sector. But really what I want to draw your attention to is this so-called oxygen ladder. And it's a way of gradually increasing the amount of oxygen support that a patient gets up to the maximum which would be referral for ICU for intubation and ventilation. And we've also added here that you should consider patients for proning if on any of these therapies their SATs are less than 90%. So as I said, I'm not going to talk about the pharmacological management because that's going to be covered in another talk. But this is an adaptation of the oxygen ladder, which has been used by other respiratory societies. But essentially, you divide your patients up into red, yellow, and green. Green patients being those who may be tachypnic, but have SATs that are more than 92%. If SATs drop less than 92%, then you can administer oxygen at the green level, which is by nasal cannula at 2 to 4, or at a maximum 6 liters per minute. You really have to be careful at giving nasal cannula oxygen at very high flow rates because it's very desiccating to the airways. Patients often get epistaxis, and the amount of rebreathing that happens at the mouth means that you don't really get reliable increases in FiO2 with increases in rate beyond 6 liters anyway. So we've chosen the target of 92 really to be a little bit more conservative because of the understanding that patients with COVID tend to tolerate hypoxia relatively well, and also out of a concern that a higher oxygen target will result in the use of more oxygen across the hospital. But if your patient is comfortable on nasal cannulae and SATs rise to above 92, then you can observe or monitor them. The next step from nasal cannula would be to move to a face mask. I showed you the oxygen ladder in the previous slide. And then you escalate up within the yellow band until the maximum, which would be oxygen at 15 liters per minute via a non-rebreather face mask. Now, some of you might find it quite challenging to differentiate between rebreather and non-rebreather face masks. We've actually in our service decided just to use the word reservoir bag face mask. Essentially a non-rebreather has got a one-way valve at the level of the reservoir bag and also some expiration valves on the mask interface itself. But those often fall off or they get pulled off by the patient. And so really, I think it would be better if we just standardize our terminology to talk about reservoir face masks. And if at this point patients still have a respiratory rate which is more than 30 with SATs less than 92, then you need an urgent clinical review to consider what the next step might be. As I said, proning, awake self-proning should be considered. And at this point, I think it's important to make a decision about the ceiling of the level of care for this patient. And that's going to be determined by your local resources as well as the patient's age and comorbidities and also their preference. And if available, this would be a very good step in the oxygen ladder to consider the use of high flow nasal cannula. Patients who are obtunded because of higher levels of carbon dioxide, those that are restless and combative, those that have got rising FiO2 requirements and are declining despite the institution of these non-invasive therapies really should be considered for intubation. And that's the logistics around intubating a COVID positive patient, infection control, and how to do it safely are going to be covered in a separate lecture. But it's important to try and maximize your non-invasive measures before you progress, but at the same time, identify patients with an altered mental state who are very unlikely to do well on non-invasive modalities. So if I'm going to give you a talk on non-invasive modalities, I mean, the big question to ask is, well, why consider them at all? For years, we have used mechanical ventilation as a means to support patients with severe hypoxic pneumonia. Well, the first point to make is that there are going to be a lot of patients who are going to require it. So although I've shown you those figures and it looks just at hospitalized patients from the previous clinical studies from China and US, we're looking at overall, it was estimated that about 2% of patients with COVID pneumonia would require mechanical ventilation. So conservative measures in the country, we're looking at thousands of ICU beds, which we know aren't available. So the first rationale was that the available ICU resources were likely to be overwhelmed. The second and probably more controversial fact is that the mortality of patients with ventilated COVID pneumonia, although variable, is pretty high. So whereas in other forms of respiratory failure, putting patients on a ventilator is something that brings relief to the treating doctor and hopefully good outcomes for the patient, it wasn't that clear that this was a strategy that was necessarily life-saving in COVID pneumonia. And certainly we know that the ICU mortality from ARDS due to COVID pneumonia is a lot higher than other causes of ARDS. And so people have questioned whether hypoxemic patients with COVID pneumonia should be routinely intubated. And I think it's important to say that mechanical ventilation still remains the fallback option for patients with severe hypoxemic respiratory failure. But, and this is a slide courtesy of the Critical Care Society of South Africa, practitioners were encouraged to look at other strategies, non-invasive strategies like proning, which is obviously not an oxygen therapy in and of itself, high flow nasal oxygen, CPAP, and non-invasive ventilation. So other measures to improve oxygenation of COVID-19 patients. And hopefully I'm going to show you how we incorporate these into our service. So firstly, let's deal with non-invasive ventilation. Okay, there are really two main groups, and the second group is divided into two separate therapies. So the first one is high flow nasal oxygen. Okay, so this really, we're going to talk about it in a few slides, but it's really not a complex therapy at all. It's a way of giving high volumes or flow rates of warmed and humidified oxygen to the patient via a comfortable nasal interface. So it gives a small amount of positive end expiratory pressure. Those of you who remember your respiratory physiology or treat patients in ICU will know that PEEP is the pressure that keeps atelectatic or closed alveoli open. So it increases the amount of lung volume which is available for gas exchange. It also raises your mean airway pressure. So it helps to increase your diffusion across your membrane of your lung. But what it doesn't do is it doesn't provide any ventilation. So there's no inspiratory support or pressure on top of PEEP. Then you talk about CPAP. So CPAP is a way of delivering higher amounts of PEEP and a kind of normal level that you would use in somebody with COVID would be about 15 centimeters of water. And that's considerably higher than with high flow nasal cannula. So it's got a much bigger effect on recruiting atelectatic lung and keeping lung units open. But it comes at the disadvantage of that it requires quite a tight fitting facial interface. Patients aren't able to eat or drink while they're on the therapy. It's quite uncomfortable. It needs to be closely monitored because the mask can dislodge and patients can desaturate. And it's also been shown to be more aerosolizing in terms of viral particles entering in the air of the immediate environment of the patient, which obviously has IPC implications and impacts on the amount of PPE used. And then there's BiPAP, or bi-level ventilation. And this is a form of non-invasive ventilation which provides PEEP, but it also provides positive pressure to help expand the lungs. So it's effectively the same as what happens with mechanical ventilation, but without a tube through the vocal cords. So if you're talking about ventilation being the amount of gas that is exchanged at the level of the alveolus, so the amount of, sorry, not the amount of gas exchange, but we all know that removal of CO2 is dependent on alveolar ventilation. And it's actually only BiPAP that provides a driving pressure or a tidal volume administered by the device to try and improve ventilation. Now, there's no question that the preferred form of oxygenation in patients that have got ARDS would be some form of positive pressure and the ability to provide PEEP above 5 centimeters of water. But as I said, this therapy is really something that can only be offered in a high care area or an ICU. It requires close monitoring, and non-invasive ventilation is associated with more aerosolization than high-flow nasal cannula. So in our setting, with the high numbers of patients expected with respiratory failure and with the ceiling on the amount of ICU beds that we would potentially be able to expand to, we were looking at other therapies, and that's really where high flow has come in. Just to quickly talk about the nasal interfaces. The interfaces for non-invasive ventilation. So as you can see here, there's a nasal interface. There's also the full face mask, which is most commonly used. And in Europe, they used this so-called helmet CPAP, which was a collapsible and inflatable bag that went over the patient's head. Apparently, it was quite poorly tolerated because it often fogged up with the patient's exhaled breath condensate. And these were usually elderly patients who were already quite delirious, and so it added to the confusion. And then here's some novel face masks that have been adapted from masks used for snorkeling and other indications. So just to quickly compare, so as I said, you've got CPAP, which will just provide a constant end expiratory pressure above which the patient will breathe normally, and that's shown by the blue line. And then you've got BiPAP, which is or bi-level ventilation, where you have delivered breaths, either triggered by the patient or just 2 different levels provided by the patient, by the machine set at certain times, but you're providing a driving pressure as well as a baseline PEEP. So I think we've briefly already discussed this. So what are the advantages of CPAP? Well, it opens atelectatic units and it increases your mean airway pressure. And that's a major determinant of oxygenation. But it doesn't supplement or augment your tidal volume. So that's a problem if you've got hypercapnic respiratory failure, which most of these patients don't have. And it also promotes a more lung protective ventilation pattern because you're not providing a driving pressure that could be injurious to the alveoli themselves. Okay. As I said, the concern is always that these machines have got a leak compensation algorithm built into their drivers. So the minute the mask becomes malpositioned and there's a leak, it will dramatically ramp up the amount of flow that's provided to the patient, and that causes a lot of aerosolization. You can kind of improve this by use of a closed system and viral filters, but it doesn't bring the transmissibility or the aerosolization risk down to 0. But then again, nothing in COVID is 100% safe. So if you're using it, how should you use it? Well, ideally, you should use it in a single room with good ventilation, and you should have the patient monitored in at least a high care setting. You should be quite aggressive with titrating the PEEP up to about 15 to 18 centimeters of water. And then you can use the FiO2 just to titrate to a SATs of about 92%. All right, so intubation and ventilation, as I said, is going to be covered in a separate talk. It's a limited resource in Africa. I'm probably I mean, I think the public was obsessed in the early days of the COVID epidemic with the physical number of ventilators that were available. And I'm talking not only in South Africa, but also elsewhere. But really the limitation to ICU care is not the ventilator. It's the provision of the specialized nursing to the patient and also the facilities. So, you know, to have all the suction and the wall oxygen and the ability to monitor patients. So, I mean, that's really in our setting been the major limitation. As I said, there's been some reserve against adopting mechanical ventilation as a universal strategy for patients with COVID-19 pneumonia, mainly because the mortality has been variable but quite high. And I've shown you those figures from 88% in New York City. We're looking at about a 73% mortality at Cretiskia, and that's involving more than 200 ventilated patients. You would use the usual ARDS net lung protective strategies, which Malcolm will talk about at the next talk. All right, so this is quite a complex slide, and maybe I can just break it down for you. But there has been increasing understanding that there are almost two different pathophysiological phenotypes that can exist at different time points in the same patient in patients with COVID ARDS. So I'm giving you two prototypical patients in this slide. And in the top slide, so as marked by the letter A, you've got a patient with severe COVID pneumonia who's ventilated, and they've got a PEEP of 5 and an FiO2 of 70%, and their PF ratio, so that's the ratio of the partial pressure of oxygen in arterial blood over the expired oxygen fraction, is 84. Again, those of you who look after critically ill patients will know that a PF ratio of less than 100 equates to severe ARDS. Okay, and we've got the scan on the CT scan on the left-hand side showing these dense consolidations and some ground glass infiltrates in the more dorsal lung units, but the ventral lung, the lung that's against the spine, is compressed. And what researchers have shown is that if you have a look at the individual lung units using quantitative HRCT, you can get a graph as shown on the right-hand side here of the amount of lung units that are either ventilated or densely consolidated. So I'll just take you through this bar graph because if you've never seen something like this before, it can be a little confusing. But what we've done here is graph the Hounsfield units. So those are the measures of the radiographic intensity of a specific pixel on the CT scan. So we've graphed the lung units according to ones that have of very low Hounsfield units on the left. So that means they are likely filled with gas, and the very solid lung units on the right. So the red bar graphs, which are consolidated and the alveoli are full of fluid. And as you can see, we've got a lung here that's got a distribution of Hounsfield units, which go from some but few gas-filled lung units, and then these very densely consolidated lung units, which predominate on the right-hand side of the graph. The second patient, I'm sorry, my animation isn't working, so it's covering the graph, but you've got somebody who's got almost an equal FiO2 requirement, so they're receiving, they're spontaneously breathing, but they've got an FiO2 of about 80%, and their PF ratio is 95. So also severe ARDS, but a very different CT or radiological picture showing few scattered ground glass infiltrates. And this quantitative CT bar graph on the right-hand side, where the lung units are disproportionately skewed towards well-aerated lung units. And essentially what we've got is a situation where the degree of hypoxia, so the degree of impairment in gas exchange or the severity of the PF ratio is really disproportionate to the amount of pulmonary parenchymal involvement. And, you know, if this was outside of the COVID kind of paradigm and we were talking in the emergency department of any hospital about a patient who was very hypoxic with a clear chest x-ray, all of you would immediately think of the diagnosis of a pulmonary embolism. So if you're going to talk about severe gas exchange abnormalities and talk about the fact that it's disproportionate to the amount of radiological involvement, then really you have to invoke a pulmonary vascular component. And what people have shown is that, and in particular Gattinoni, who those of you who work in ICU will know is one of the doyens of ARDS, have shown that what happens in COVID pneumonia is that there's loss of hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction is a normal physiological response, which is present in all of us, which vasoconstricts blood supply to poorly ventilated lung units in order to prevent shunting. So normally what happens is blood that would pass through an area of the lung that is not participating in gaseous exchange would return to the arterial side of the circulation with the same oxygen content as mixed venous blood. And that contributes to shunt. So what hypoxic pulmonary vasoconstriction does is reduce blood flow to those units, pushing blood flow through the better ventilated lung units and therefore increasing the amount of oxygen on the arterial side of the lung. So if you understand that physiology, you will know that in these patients with the more pulmonary vascular involvement, so the second type of lung pathology, they are not going to respond very well to mechanical ventilation. What they need is their oxygenation increased. And so this brings us to high-flow nasal cannula, which, as I said in my early slides, is really not a very complex piece of technology. It is, these are its components. The components include the unit itself, which really is a humidifier and a warmer, and then some consumables, which we'll discuss in a second. And what it does is it blends oxygen from the wall, so oxygen from the hospital supply, with the room air to deliver a high flow of gas. And I'll show you why a high flow is important, regardless of what the FiO2 is. And generally in adults, we would use a flow rate of between 35 to 60 liters per minute. What are the advantages of high-flow nasal cannula over other forms of non-invasive ventilation? Well, I think the first one, which I actually haven't put here, is that it's not very complex. I mean, when you're managing large volumes of patients with respiratory failure, it's good to have an intervention that doesn't cause anxiety among your staff when it needs to be instituted. So using ventilators, intubating patients, setting up patients on non-invasive ventilation. If this is not part of your general or normal practice outside of COVID, it may come with some stress and anxiety about using. Whereas high-flow nasal cannula really is a plug-and-play device. One of the advantages is that it's got a nasal cannula that just sits on the top lip. There's no need for a tight seal. You're able to eat and drink, and then you can also wear a surgical face mask at the same time. So that helps to reduce aerosolization and does have some IPC considerations. Really, the most important attribute of high-flow nasal cannula is that the gas or the gas mixture that the patient receives is heated and humidified, and this avoids airway injury. And we have seen in patients given double oxygen or dry nasal cannula oxygen, necrotizing tracheobronchitis. So actually desiccation and sloughing of the airways in the major airways, of the epithelium in the major airways because of non-humidified oxygen. So it's very well tolerated by patients and they feel pretty comfortable. How does it work? Well, probably its most important physiological action is the washout of dead space. So you'll remember that in every tidal volume breath, there's a percentage that is just taken up by gas, which is in the conducting airways of your lungs. So your major bronchi and your trachea. So parts of the lung that don't take part in gas exchange. And when you are severely hypoxic, unfortunately, anything that you give to the patient has to be diluted in this dead space ventilation. And what high flow does is by continuously providing this high concentrate or this high flow rate of gas, it washes out the dead space in the major conducting airways, but also in the naso and oropharynx, so that each breath that the patient takes is full of the FiO2 that you've set on the machine. I've already shown you how the application of a small amount of PEEP is possible with high flow. and that does support respiratory mechanics and can decrease the work of breathing, although clearly this is not in any way to the degree that is offered by non-invasive ventilation. And then, as I said, because it's providing this amount of FiO2 directly almost at the level of the gas exchange airways, you are providing a reliable FiO2. And that's very different with a mask interface, where the amount of oxygen that the patient actually gets depends very dramatically on their own respiratory rate and their own minute ventilation. So on the amount of mixing that's happening at the mouth. So high flow therapy is something that's widely endorsed. In the early stages of the pandemic, there were some concerns around aerosolization and efficacy, but it's been adopted by several respiratory societies internationally, and more importantly by the WHO as well as the Centers for Disease Control. It's important to also say that there aren't a lot of good studies confirming its utility in acute hypoxemic respiratory failure and COVID, and most of what we know has been extrapolated from studies of bacterial pneumonia. These are the Society for Critical Care Medicine guidelines for the treatment of COVID pneumonia with hypoxia. And you can see that in patients who aren't tolerating supplemental oxygen via the normal oxygen ladder, it is considered as an alternative. However, the major disadvantage of high flow nasal cannula oxygen is that it has severe demands on the local oxygen supply. So I'm talking not only about the total oxygen supply of the hospital, but also dependent on the reticulation of the actual pipes that deliver oxygen to the bedhead. So the flow rate that you can run at is often determined by the diameter of the pipes that reach each individual oxygen plug at each bed. And while that might not be significant for the individual patient or two, if you're trying to dramatically upscale this technology or this intervention, you may find yourself in a situation where, particularly if you've got patients in series along a bed head or more than a certain number of units per cubicle, that you might be running into oxygen supply problems. So this is something that you need to talk about with your engineers at your hospital. And then just to show you that on the left-hand side, the top left-hand picture, so those three tanks that you see, the two small ones and the big one, are called vacuum insulated evaporators. So they are tanks that hold liquid oxygen, which obviously expands to a much bigger volume when it boils and becomes a gas. And the two small tanks on the left-hand side is what we used for two hospitals, for Critics Care and the Netcare private hospital, which is alongside it. And that very big 20-ton tank. So those are 3 and 4 ton tanks each. And that very big 20-ton tank that you see on the right-hand side was installed in the early stages of the COVID pandemic, particularly to cope with the so-called increased oxygen demands. And you can see from the graph below that the amount of oxygen goes up in a stepwise fashion as we got more and more high-flow machines and were able to treat any more patients. So we were looking at the peak about 8.5 to 9 tons of oxygen, of liquid oxygen a day. So it's very heavy on oxygen demand. And the last picture on the right-hand side just shows that when you get huge volumes of liquid oxygen traveling through your evaporators, so remember these are converting liquid oxygen into gas, so that process is called boiling, and you can see that the flow through these pipes of cold gas is so high that it causes a lot of precipitation of ice around them, and these pipes need to be de-iced on a very regular basis. So let me just talk a little bit more about the dead space washout. So here is on the left-hand side is a fancy fluid dynamics model of how nasal cannulae provided at the nose. Hopefully you can see my cursor here, but those are the cannulae there. This space here represents the nasopharynx and the oropharynx going down here to the trachea. And you're blowing air in through the nose, but it's washing out all the space, including going down the trachea and coming back out the mouth, so that when the tidal volume is drawn in by the patient, the reservoir is actually physically in the nasopharynx and oropharynx. And it's almost analogous to being able to move the reservoir bag of 100% oxygen or of high FiO2 of oxygen into the conducting airways. It depends on what the patient's own respiratory rate is, but generally, if you're going to flow at 40 to 60 liters, you're going to far exceed the patient's own minute ventilation. So it allows you to exceed the amount of mixing that occurs in tachypnic patients. This is just a slide showing you the small amount of PEEP that's delivered. It's improved if patients close their mouths and is highest at peak expiration. And you can see 4 to 5 centimeters of water is really the maximum that you will achieve. So when do we use high flow? Well, in patients who have got either confirmed, or as the pandemic evolved, we started putting patients that we were pretty sure met the clinical definition for COVID-19 pneumonia on high flow. I've already told you that the SATs of 92%, despite oxygen via reservoir bag mask at 15 liters per minute, was usually the trigger. We gave it to patients who were awake and cooperative. And I think it's important to just stress that confused, combative, hypercapnic, or actively deteriorating patients should be intubated rather than trialed on high flow. Other contraindications include hemodynamic instability, and I think I've already stressed the importance of an altered mental status. Clearly, one of the major considerations is going to be where you do high flow. And although prior to COVID, I don't think anyone ever considered offering this outside of at least a high care, but probably an ICU. We've done this in the high care area of COVID wards. And really, when I call it high care, it's high care in name only. We haven't got high care nursing ratios. We've used fairly basic monitoring, including, in some cases, just fingertip pulse oximeters. We've tried to minimize the amount of blood draws. So occasionally we've looked at venous blood to look at the pH and the PCO2, but there certainly isn't a requirement for regular arterial blood gases. And then it's been very difficult to be able to categorically give criteria for intubation. And generally, this decision is made not just on a blood gas or on a SATS level, but on a more composite clinical assessment of how the patient is doing in terms of their mental status and their own subjective perception of their work of breathing, as well as things like respiratory distress and respiratory rate and use of accessory muscles. How do we do it practically? Well, we start flow at 50 liters and titrate the FiO2 upwards to maintain saturations at 92. We increase the flow at 10 liter per minute increments if the respiratory rate fails to improve. And as I said, patients can also wear a face mask. And importantly, particularly if you've got low nursing ratios, is that patients can take in orally and feed themselves. So they're able to do a lot of their own self-care. The disposables include a humidification chamber, a heating tube, a nasal patient interface, and an air inlet filter. And how you set the machine is very important because there are actually very few things that you can set. There's oxygen at the wall, which often comes with its own flow meter, which can go up to 50 to 60 liters per minute. Again, that's the oxygen flow rate. And then there's the total flow that's given by the machine. And remember, that's the bulk flow that does the washout. And that is a amount of between 50 and 60 liters. And the FiO2 is determined by the ratio of those two. So it's a fraction where the numerator is the oxygen flow rate and the denominator is the total flow rate. So what do you set on the machine? Well, you are only able to really alter two things. The first one is the temperature, and that's really just within a range of 31 to 37. Depends on how comfortable the patient is. Sometimes patients complain that it's too warm. The flow rate is preset on the machine, and as I told you, we've been using between 30 and 60 liters. And then the FiO2 is not something that's dialed in, but it's determined by that equation that I showed you in the previous slide and is measured by the oxygen analyzer. So if you want to increase the FiO2, you need to increase the amount of oxygen on the flow meter. Well, the big question people ask is, what about aerosol generation? Well, it's actually, this risk is thought to be overstated. There's some studies that have looked at dispersion of particles. I mean, these are not infectivity studies. These are just droplet dispersion studies. And they've shown that high-flow nasal cannula probably has a lower droplet dispersal than other forms of oxygen administration. And interestingly, in this study, it was lower than patients who were getting oxygen via a Venturi face mask. So it seems that the risk of aerosolization of high flow is largely overstated. And it's just important also to compare with NIV in patients with a full face mask. So this is, or CPAP via nasal pillows or an oral mask, which can be also low, but also very high if there's dislodgement of the mask interface. So a question we ask quite often is what is proning and how does it help? And I think Malcolm will also cover this in his talk, and I realize that I'm running out of time and that we want quite a lot of time for questions. But essentially, if you suspend the lungs from their bases, so in other words, the ventral side, you stretch out lung units and you allow lung units that were previously collapsed to be aerated. And you also help to match the blood flow of different lung units to the amount of gas that they have in terms of ventilation. And we call this the VQ ratio. It's got many mechanisms of action, which I won't go into in great detail. But essentially, we know that ventilated patients, if you turn them from the supine position on their back to the prone position, there are improvements in oxygenation. So that's shown here with the red dots in the supine position versus the gray dots in the prone position. And that this is not only an improvement in oxygenation, it also comes with an improvement in mortality. And this is a study of ventilated patients called the PROCEIVA study. And it's notable in the ICU literature because of its very strong positive outcome. They randomized patients to either 16 hours of proning versus no proning. And the mortality was significantly different, 23.6 versus 41%. And so it's unsurprising that people have suggested that the same would apply to awake patients, because of course the physiology remains the same. And the graph on the right-hand side shows you the same kind of cyclical increases in PF ratio as patients are moved from the supine to the prone position in COVID pneumonia. All right, so we said we talk about prototypical patients. So this would be one of the patients that we would see quite commonly, although fortunately things are starting to plateau, but we would have several referrals like this a day. A 56-year-old woman from an informal settlement outside Cape Town who's been symptomatic for 7 days. She's transferred from a peripheral hospital where she's been there for 2 days. She's not a smoker, but her risk factors for severe COVID are that she's got an elevated BMI. She's been diabetic on oral agents, but her admission HbA1c is 10%. She's HIV positive, and she's got severe gas exchange abnormalities. So her PO2 is 6.5 kilopascals. So that's about 50 odd millimeters of mercury for those of you who use that unit. And her PF ratio is 86. So again, meeting the criteria for severe ARDS. She gets transferred on so-called double oxygen, which in our setting means a reservoir face mask plus nasal cannula at 15 liters. She's got a normal cardiac examination, but she's got prominent bibasal crackles, and she's awake but visibly distressed. Her bloods show a lymphopenia with normal renal function. Her last HIV viral load was suppressed, and her CRP is 75 with a positive D-dimer, and her SARS-CoV-2 swab comes back positive. How would we manage this patient? Well, we'd initiate high flow at 60 liters a minute with FiO2 of 90%, wake prone her. We'll anticoagulate her with low molecular weight heparin according to her weight. She'll get dexamethasone as per the recovery study. We'd quite aggressively target glucose control, and we'd consider cautious intravenous fluids if she's too breathless to take orally. She'd be monitored via a continuous pulse oximetry, so she wouldn't necessarily have an ICU monitor with an ECG. And we found that the first 6 hours are particularly important to reassess for signs of deterioration and the need for intubation. So in this next slide, I'm just going to show you what our outcomes have been. And I just want to credit a couple of people who've helped with the data collection. And this is Gordon Audley, who's one of the medical registrars, Pindile Gino, who's one of our pulmonology fellows, and Christelle Arnold-Day, a consultant and fellow in the ICU service. So we've treated, we've treated about 400 patients now, but at the time we did this analysis, we had about 290 patients we treated with high flow at both Stellenbosch, so Tygerberg Hospital, as well as at UCT, at Credo. And of those, about 47% or 46% were able to be weaned without requiring intubation and ventilation. So this is quite impressive, because if we look at the PF ratio in that group of patients, their median PF ratio is in the 70s. So again, these are people with severe ARDS that, you know, November 2019, all of us would have intubated and ventilated without hesitation, and yet they are able to be managed often in a non-ICU setting on high-flow nasal cannula alone. And gratifyingly, the majority of these patients have survived to discharge. So as you can see, we've only got one patient who subsequently died after being treated with high flow. The corollary is that if those patients fail high flow and go on to receive mechanical ventilation, and as you can see, there's a sizable proportion of those, 74% of them will die on mechanical ventilation. And there is a group that are still being ventilated after several weeks, but clearly the mortality in ventilated patients is higher. It's possible that those who fail high flow represent a sicker group of patients from the very beginning, but our preliminary data at Credo shows about a 25% survival for mechanical ventilation overall. If you are going to use this therapy, you need to be patient. So the blue line shows the time to intubation or high flow failure in patients that are on it. And if you're going to succeed, it's going to take a lot longer. And in fact, our longest survivor, who isn't in this cohort, was on high flow for 40 days. And we calculated used 2.5 tons of oxygen during a hospital admission. So this is not a therapy where you're going to be able to turn over patients very quickly. And in fact, our median time on high flow is 8 days. So you must expect patients to be on high flow for at least a week. All right, so that brings me to the end of the didactic part of this the Zoom call. The take-home points are that 20% of hospitalized patients with COVID will develop acute hypoxemic respiratory failure and will need some form of support. And clearly, we don't have the infrastructure to be able to cope with all of those patients in an ICU. High-flow nasal cannula is something that you can consider. Depending on your setting, CPAP or non-invasive is probably even better, but is much more difficult to scale up and requires more intense monitoring, and definitely more in terms of ICU support. If you are going to use high flow in limited resource settings with poor access to ICU, you've got the potential to save at least 1 in 3, if not 1 in 2 lives, and that's at a much lower cost than ICU admission. I've told you that survivors require the therapy for at least a week. Probably the most problematic issue is that that the threshold for intubation is very difficult to define. And it is variable depending on what your setting is. I mean, if you're having to intubate somebody and send them long distance, and you know that the outcomes of mechanically ventilated patients are not great, you may be pushed to carry on longer with patients on high flow than you would if you had ready access to an ICU. So it's going to be site specific, and it's difficult to set clear criteria for when patients should be intubated. And really just to say that if you are going to consider using this, you require ongoing monitoring of both the local capacity of oxygen at your hospital and also that of the reticulation at the bedhead and the oxygen supply chain. Lastly, I'd just like to acknowledge the big teams at Credo and at Tygerberg who have been looking after these patients over the last couple of weeks. Thanks for your time. I apologize again that I started the talk late, and I'm happy to take any questions. I'm going to stop sharing my screen.
Thank you so much, Greg. There are questions on the Q&A. So I know you don't have time to be writing, responding, but I'll invite you to read them and respond to them. Yeah.
Okay, so I'm going to just go down the questions as we go. Is it possible to achieve high flow with the normal nasal cannula and a 40% face mask? The answer is absolutely not. I mean, unfortunately, it's the bulk flow. So you have to reach 60 liters of flow, or at least 40 to 60 liters. So unfortunately, 15 liters plus 15 liters doesn't actually equal 30 liters. The flow is still only 15 liters. So I would, yeah, I mean, unfortunately, it's not equivalent. The next question is, what's my take on the use of hydroxychloroquine? Well, I mean, I think you could also put that to Prof. Mankies when he talks about pharmacotherapy. But I think that every randomized trial of the use of hydroxychloroquine in severe patients, in mild patients, in prophylaxis, has all been negative. So, I mean, I don't think that it's really a therapy that we should be being considered. The next question from Jean Mittel is, why do the three categories of respiratory distress, green, yellow, and red, have the same values of respiratory rate and oxygen sats? So I'm sorry if that was unclear, Jean or Jean. What we mean to say is that at each one of those levels correspond to certain types of support. And if you still don't meet the goal of SATs above 92 and respiratory rate of less than 30, then you go up